Hi, everybody. Thanks for joining us today. Um, Today's topic is a follow-up to our first part heel pain lecture, where we spent the lecture discussing the most common cause of heel pain, which is plantar fasciitis or heel spur syndrome. Today, we'll spend a little time talking about other causes of heel pain and give you some tips and things to think about. So thanks for joining us, and here we go. All right, so as discussed previously, plantar fasciitis is the most common cause of heel pain. It typically causes pain on the bottom of the heel. And when a person is evaluated for heel pain, in addition, other conditions to rule out include stress fractures and bone cysts of the heel bone. But another common condition is tarsal tunnel syndrome. So we'll discuss tarsal tunnel syndrome. And in addition, we'll discuss pain that can develop on the back of the heel near the Achilles tendon. So we'll discuss Achilles tendonitis as well as Haglund's deformity, which are pretty similar. So risk factors are consistent with all of the problems. Again, these problems can affect people with all foot structures, whether a person is extremely physically fit or overweight. They can have these problems. Very common people who participate in a lot of athletic activities and high impact activities, or work all day and stand out all day on hard surfaces. Poor shoe choice is a major cause of these problems. But essentially, these problems are wear and tear type of injuries. Typically, they're most common between the ages of 40 and 70, but again, can start much earlier in life. These conditions typically are not caused by an injury or a traumatic event, but there is the possibility of an injury triggering these problems. So first, we're going to talk about tarsal tunnel syndrome. I'll give you the definition here first. The tarsal tunnel is a narrow space that lies on the inside of the ankle next to the ankle bone. And the inside of the ankle, for the purpose of this conversation, it may seem obvious, but just in case, the inside ankle bone is the ankle bone on the side of your big toe. So the tarsal tunnel is on the medial side or inside of the foot. And the tarsal tunnel is covered by a thick ligament called the flexor retinaculum, which I'll point out here in a second, but that's important to note. And the structure that is irritated in tarsal tunnel syndrome is the posterior tibial nerve. So tarsal tunnel syndrome itself is a compression or an irritation or a squeezing of the posterior tibial nerve in the tarsal tunnel area of the foot. So the tarsal tunnel area of the foot is similar to the carpal tunnel of the wrist. So here in this diagram, in this picture, just for a reference point, my cursor over here to the right of the screen is at the inside ankle. And if we go to the left picture here, this is showing the structures of the tarsal tunnel. This blue turquoise type band here is the flexor retinaculum that I mentioned in the previous slide. And, excuse me, within this tunnel, we have several tendons along with an artery, a vein, and the posterior tibial nerve, which is this yellow structure here. So with tarsal tunnel, the symptoms, typically a person can experience pain along the course of the posterior tibial nerve, and the pain can be isolated to the area of the ankle joint, but the pain can radiate towards the knee, and it can also most commonly radiate to the arch of the foot or to the bottom of the heel, and it can cause symptoms that are similar to plantar fasciitis. So the pain can be a radiating pain, a burning pain, sharp stabbing pain. Sometimes people will describe an electric shock or a hot poker that kind of stabs them comes and goes very quickly. A person can also experience numbness and tingling sensations. And the pain does tend to increase the longer a person is on their feet. The pain seems to increase over a period of time. So again, the left picture here, it just shows a drawing of the posterior tibial nerve. So the posterior tibial nerve, if you follow my cursor, the ankle bone is right here, and the posterior tibial nerve comes down towards your heel, and it splits into these branches that wrap around to the underside of the foot. And you can see these nerve branches right here, which correlates to this blue area, and that can cause heel pain. But again, a person can experience pain into their arch and into their toes, depending on which portion of the nerve is irritated. In the slide, I have written sometimes the symptoms of the symptom appear suddenly, and typically that actually is the most common scenario. It's something that just kind of shows up one day. Again, there's not typically a traumatic event. It's more of an overuse type of injury and foot structure injury. A lot of times it can develop in a person who's beginning a new exercise program, activities that they aren't typically used to. Tarsal tunnel syndrome affects approximately 2,000. There are 2,000 cases a year in the U.S. It is slightly more common in women than men, but it affects both. And again, it can affect a higher arch person or a flat-footed person, but it seems to be more common in the flat foot structure. So it is important to seek early treatment if you're having any of these symptoms of tarsal tunnel syndrome. The reason being is there is a buildup of pressure within the tarsal tunnel, or there can be a mass within the tarsal tunnel, which we'll talk about here momentarily. But the longer the nerve is compressed, it can lead to permanent damage of the nerve, and a person may not be able to get complete relief of symptoms if there is permanent damage to the nerve. So again, as mentioned many times already, the symptoms of tarsal tunnel syndrome can be similar to other conditions such as plantar fasciitis. So history is very important when you go to your physician. History, being very specific about the type of pain and the nature of pain that you're having, when the pain occurs. Does the pain increase as time goes on? Do you feel weakness? Things of this nature. The physical exam. The first thing that the foot specialist will do will evaluate your foot structure, because the foot structure, depending on a person's foot structure, can dictate the way that it's treated. Typically, the area of the tarsal tunnel will be palpated, and either just with palpation, we'll press the area, and what we're checking for is a mass or a lump in the area of the tarsal tunnel. And we'll also do a light tapping of the nerve just to see if just a light tapping or a light pressure. Usually if a nerve is irritated, it doesn't take much to reproduce the discomfort, because basically the nerve is on high alert. It's just agitated. And as mentioned in our previous lecture, tight calf muscles are a major factor in tarsal tunnel syndrome for many people. X-rays are important and will be taken. And again, what we're looking for is we are looking for bony abnormalities, but that could possibly be impinging on the posterior tibial nerve, such as a bone spur, especially if a person's had a prior injury, if there's some type of arthritis, either from the injury or bone spur, either from arthritis or a previous injury. But again, what we're really looking for is the foot structure. And it's important to see the alignment of the bones when a person, on an x-ray, when a person is bearing weight on their foot. So non-weight bearing x-rays. If you have x-rays taken at your primary care doctor's office and weren't standing on the foot while they were taken, they're really not much use to us. Also, during exam, if it's sometimes a person will be able to do what we call a diagnostic nerve block injection. So we'll use an anesthetic and we'll place it in the area of the nerve. And if a person's symptoms, when they leave the office after the anesthetic kicks in, if the person's symptoms are resolved, if that burning sensation goes away or that stinging sensation goes away, then that nerve block helps us diagnose tarsal tunnel syndrome. At times, it may be necessary to have an ultrasound or an MRI. The ultrasound or MRI typically is evaluating the tarsal tunnel to see if there is a cyst formation, such as a lipoma, which is a benign fatty cyst, or a ganglion cyst, which is a benign cyst that can commonly form within the tarsal tunnel and compress the nerve. Also, an MRI can help pick up the main vein to the bottom of the foot is within the tarsal tunnel. So sometimes a person can have a varicose vein that is not a deep varicose vein that is not noticeable just by looking at the foot, and that varicose vein, because it's bulging, can compress the nerve. At times, we may send a person for an EMG or nerve conduction velocity test to look for an impingement of the nerve, or to make sure the nerve is or is not functioning properly. Sometimes these tests, even in a normal test, the test may be normal, the nerve's functioning properly. So just because a person has a negative EMG NCV test does not mean that they have tarsal tunnel syndrome, but it can be helpful at times, and that's usually at the discretion of the treating physician as to whether or not a person requires one of those tests. So treatment for tarsal tunnel syndrome, it's the usual suspects: rest, ice. Sometimes there's just an inflammation of the nerve, especially, or inflammation of a tendon, the tendon within the tarsal tunnel. And in the early stages, just by reducing that inflammation, it can improve the symptoms of tarsal tunnel syndrome. Immobilizing or resting the ankle and taking some work off of the ankle in the area of the tarsal tunnel or the irritated tendon with a walking boot or an ankle brace. There's a motion in people who are flat-footed that we refer to as pronation. And sometimes when the tarsal tunnel or the tibial nerve is really irritated and a person also has pronation, these braces can help stop the pronation so that the nerve can rest. Physical therapy can be extremely helpful. Physical therapy can be beneficial for stretching and strengthening exercises to correct muscle imbalances that may be causing the problem. But there is also therapeutic ultrasound and other modalities that can reduce the inflammation of the nerve or whatever structure is inflamed and pressing on the nerve within the tarsal tunnel. So we have therapeutic ultrasound, different laser therapies nowadays, light therapies, and so on. Orthotics, if there is excessive pronation and a flat foot structure, orthotics can reduce the pressure to the tarsal tunnel by stopping or reducing the amount of pronation that a foot undergoes. And then injection therapy. Sometimes I mentioned previously that an anesthetic such as lidocaine can be used as a diagnostic block, but it has long-acting anesthetics can also be therapeutic and numb the nerve for quite a long period of time. And then also cortisone can be extremely beneficial. Sometimes a person will come in maybe with a couple months history of tarsal tunnel syndrome. There's some mild inflammation within the tarsal tunnel, and sometimes one cortisone injection is enough and it knocks out the inflammation for an extended period of time. Tarsal tunnel surgery. Just like anything else, we try the conservative treatments, but if a person requires tarsal tunnel surgery, it can be an extremely successful procedure. And basically, it's very similar to carpal tunnel surgery. It's basically we perform a tarsal tunnel release. And what we do is, and I'll show you a picture here in a second, but we release the flexor retinaculum, is that band-like structure that is holding the tendons down. Because of the buildup of pressure within the tarsal tunnel, by releasing the flexor retinaculum, it releases the pressure within the tarsal tunnel, and that way the nerve is no longer compressed and it can heal. Also, if a lipoma or a ganglion cyst is noted to be present in the tarsal tunnel, that is also removed at the same time. It's an outpatient surgery. If a person has been dealing with tarsal tunnel syndrome for a long period of time, there may be permanent damage to the nerve, and a person can continue to experience some level of symptoms even after a tarsal tunnel release. Although a majority of the time, a person's symptoms are significantly improved. Most people, if it's caught early enough, the discomfort is alleviated entirely. But again, it's a compression type injury, and the longer a nerve is compressed, it doesn't matter if it's in foot and ankle area or another part of the body. When the nerve is compressed for a long period of time, there is the potential for permanent damage being done to that nerve, and that's why at some point, sometimes a person will continue to have mild symptoms even after a tarsal tunnel release. So the nerve, quite often, a nerve after it is being decompressed with a tarsal tunnel release, it can take up to 18 months for complete recovery. What I mean by that, the incision heals within a couple of weeks, and a person is walking on it back to activity after several weeks. What I mean as far as the recovery, the 18 months, sometimes it takes 18 months for the nerve itself to calm down. So this diagram right here, or this picture, so this area right here where my cursor is the ankle bone, and this, of course, is marking the Achilles tendon, and this would be the incision for a tarsal tunnel release. This diagram is showing the release of the flexor retinaculum, and you can see right underneath the flexor retinaculum is that tibial nerve. And again, this is a good diagram. It can also show the branches of the tibial nerve that are going down towards the heel. So this is why when a person comes to our office, again, plantar fasciitis being the most common cause of heel pain, but we also, based on the history given to us by the patient in the physical exam, we often can differentiate between the two. So Postoperatively, it is an outpatient surgery. You'll have a large, bulky dressing on your foot. The most important thing postoperatively is to allow the incision to heal. So technically speaking, a person can put weight on their foot following the surgery, but the less the less time you spend on your foot in the first couple of weeks, the quicker the incision will heal. And once the incision heals, you can increase your activity as tolerated. This is, with the tendons passing in this area and being in the ankle joint, the more the foot moves up and down, it just can slow the healing of the incision if you don't take it easy. Very rarely is a person non-weight bearing for this problem. Typically, a person is weight bearing with protected weight bearing in a boot or a shoe following surgery. Physical therapy in my practice for tarsal tunnel syndrome, once a person's incision is healed, say at 2 weeks, an incision typically heals at 2 weeks. Once the incision heals at 2 weeks, I typically have a person start physical therapy right away because it helps reduce the swelling. And remember, the buildup of pressure within the tarsal tunnel is part of the problem. So if we have surgery, it's going to induce some swelling or buildup of pressure, and the physical therapy helps get that, relieve that a little quicker. Typically, though, high impact activities, running and jumping, typically, again, there are outliers as far as patients are concerned. Some people will be able to get back to those activities sooner, but typically it's about a 3-month, as long as a person's muscle strength is good, stability is good, and they can do it comfortably. It's usually about 3 months or so after surgery before they can start high impact activity. Of course, if surgery is on the left foot and you're not pushing a clutch for a stick shift, you can drive right away as long as you're not taking any pain medications. If a person has a surgery on the right foot, there's a period of no driving. Again, this is something to discuss with your surgeon, but it may be several weeks, sometimes 3 weeks, 4 weeks, just to make sure you have the strength to push a gas pedal, press on a brake. So that was tarsal tunnel syndrome. So next we're going to talk about insertional Achilles tendonitis. So this is pain at the back of the heel bone. So of course, we all know where our calf muscles are, and our calf muscles then turn into the Achilles tendon, and the Achilles tendon inserts onto the back of the heel bone. So the reason this is called insertional Achilles tendonitis, there are different sections of the tendon, but this is inflammation of the tendon where it attaches to the heel bone. So when a person comes to the office, again, we take the history and physical, and we will take x-rays. And x-rays are very important because, of course, they give us foot structure. This tends to be a little more common in a person with a higher arch. But essentially what happens, a person may or may not have a spur formed on the back of their heel bone. So if anybody is listening that was on my plantar fasciitis lecture, the presence or absence of a heel spur for plantar fasciitis really doesn't, it's the same surgical procedure whether or not a person has a heel spur present or not. For pain on the back of the heel, it's important to know if a person does end up requiring surgery, it is important to know whether or not a person has a heel spur, because in that case, the heel spur does need to be removed. But when a person is having pain at the back of the heel, in this case, most of the time, a spur is present, like is seen in the left picture. But at times, a person has pain at the back of their heel and there's no presence of spur, which is a good thing. Typically, when we look at the foot, we'll typically notice a bump on the back of the heel. This is a very common presentation. Of course, you can see the Achilles tendon coming down, and where it attaches to the heel bone, we see these bumps. X-rays are important. Sometimes your physician will order an ultrasound or an MRI, and the reason being is where the Achilles tendon attaches. If we go back a slide or two, when the Achilles tendon comes down, if a person has this little spur, oftentimes that spur, when a person is walking, the Achilles tendon is rubbing up and down against this spur. And when they're walking for a long period of time and there's friction between the spur and the Achilles, at times the Achilles tendon can develop a little tear or a split in it. And an ultrasound or an MRI often is done because for surgical planning purposes, it's important to know prior to the surgery. So you shouldn't be surprised if your doctor orders one of those tests. So this is an MRI. The middle picture is, if you follow my cursor, this black structure right here is the Achilles tendon, and this is a normal Achilles tendon. You can see that it is pretty much the same thickness as you follow it down all the way to the back of the heel bone. The picture on the left, you can see, again, starting up high, you follow the Achilles tendon down and you can see how it fattens or gets wider here. And then going back to the middle structure, a healthy tendon is black all the way through, it's solid. On an MRI, we've got the black tendon here, but we see the white within the tendon itself, and that is a sign that there are little tears within the tendon. So in addition to being important for surgical planning purposes, it's important for the patient to realize that when the tendon is weakened and chronically inflamed from those little splits, it's necessary. A person's at a little higher risk for a spontaneous rupture of the Achilles tendon. Now on the right side, the right picture, we again see the Achilles tendon coming down and the inflammation. We can see that there's inflammation directly at the insertion. And then also this white, so bone is also, if you look at all three of these pictures, bone is black or gray. But when we see the white, there's fluid, and you can see fluid in this case is inflammation. So we can see inflammation within the heel bone itself, which is telling us there's a lot of friction between the bone and the Achilles tendon. So this is a picture of, sometimes a person can come in, and if you look at this bone, this oval piece of bone right here, you can see that it's separated from this little spur right here. So typically this is calcification within the Achilles tendon itself, meaning that the Achilles tendon had some splits in it, but or tears, but when it healed, those little tears calcified. So typically when a person has this problem, it's very difficult. A person can get better without surgery, but it is much more difficult because of there's not a lot of room between the Achilles tendon and the bone spur. So something has to typically be done to relieve the pressure. So conservative treatments, again, just like anything else, rest, ice, and non-steroidal anti-inflammatories. So for many conditions, not just in the foot and the ankle, but other parts of the body, we can use cortisone for inflammation. But cortisone is not an option for this part of the foot. Oftentimes, a person comes in and says, well, can't you just give me a cortisone injection back here? But you can. In fact, it's not indicated, it's not recommended. It's really bad medicine. The cortisone near the Achilles tendon insertion can dry the Achilles tendon out and make it very fragile, again, leading to a spontaneous rupture. Physical therapy, if there is no presence of spur, physical therapy can be very beneficial, again, in loosening up the calf muscle and calming down the inflammation. This does have the tendency to take several months to a year to resolve because of the amount of work that the Achilles tendon undergoes, just with regular everyday living. So it can be a frustrating problem. Most of the time surgery is, oftentimes surgery is necessary, but in reality it's most of the time. The MRI is typically indicated, or ultrasound, because it may be necessary to clean up the Achilles tendon or repair the damaged tendon. If a person has extremely tight calf muscles, when we do this procedure, it is sometimes necessary to do a small procedure called a gastrocnemius recession, where we lengthen the gastrocnemius muscle or Achilles tendon slightly just to relieve the tension at the heel bone. Even in the absence of a spur formation in a person who's not getting better, oftentimes a gastrocnemius recession can be beneficial, again, just in and of itself, just to relieve the tension to the back of the heel where the Achilles tendon attaches. The procedure for this is actually technically simple procedure for the surgeon. The procedure typically takes much less than an hour. It's an outpatient surgery. What makes this procedure difficult at times is the recovery can be lengthy, and because oftentimes it's necessary to remove the tendon from its attachment to the heel bone in order to get to the bone spur. And the lengthy part of healing is allowing the tendon to heal back down to the heel bone. So of course the Achilles tendon is a very important structure, so we need it to be well attached to the heel bone. So sometimes a person has to be non-weight bearing for an extended period of time for that to happen. Typically, again, on the left shows the incision placement. Middle picture shows the little bone spur, and the right side. So basically, if you look at the middle picture, of course, we've got the heel spur where my cursor is, and then we've got this corner of bone or edge of bone right here that is prominent, and you can see the shadow of the Achilles tendon coming down. So not only does a person have a spur, but they have this portion of the bones irritating the Achilles tendon. So in this case, we removed the spur and we also rounded off the heel bone in this area, kind of rounded like this, so that the Achilles tendon no longer receives friction in that area. But this picture also shows these little corkscrew objects. Those are called soft tissue anchors. They're very similar to soft drywall anchors. In this case, we had to peel away the Achilles tendon, and then in order to attach it back down to the heel bone, we have to use these soft tissue anchors, which have sutures coming out that we pull through the Achilles, and we tie the Achilles back down to the heel bone. This is typically what it looks like. So we can see the Achilles tendon was split down the middle and then opened up so we can visualize the spur. But in this case, we also had to, in this diagram, the incision across the Achilles here had to be peeled away from the heel bone in order to get to the spur. And this is a type of soft tissue anchor. We can see that's going into the heel bone, and these are the sutures that come out. And we by tying it, it pushes the Achilles tendon back against the heel bone. Technically simple procedure for a surgeon. Typically, the most difficult aspect of the surgery is the recovery. The first thing I typically talk about with the patient is that you have to get it in a mindset that you have to be extremely patient. You have to be a patient for this thing. Typically, there's no high impact activities for 4 to 6 months. There can be a period of non-weight bearing. If we don't have to detach the Achilles tendon, it's a shorter length of time of non-weight bearing. If we have to reattach the Achilles tendon with soft tissue anchors, typically there's no weight bearing for at least 8 weeks. Again, because the Achilles tendon is such an important structure, and we want the strength to return as quickly as possible. Physical therapy is often recommended. But again, patience is very important. If any of you are sports fans, you know that any athlete that has an Achilles tendon injury or Achilles tendon surgery, they make millions of dollars doing what they do, and for them to miss half a season or the entire season is a very costly endeavor for them at times. So if a 25-year-old, very well-conditioned professional athlete has to miss 6 months or half a season, then typically people like us who aren't professional athletes or high-level athletes, we're no different. So you just have to get in the proper mindset. Haglund's deformity is very similar, to a insertional Achilles tendonitis. It's just a subtle difference. And basically, this is also referred to, you may have heard of the term a pump bump. And this is basically just an enlargement of the back of the heel bone. There's not a spur within the Achilles tendon itself. And it is more common in a person with a higher arch foot as opposed to a lower arch foot. Again, redness, irritation, swelling in the back of the heel, very, very similar. But again, this is why x-rays are important and history is important. Your doctor will be able to differentiate between the two. The Haglund's deformity is typically, I'll go back a couple slides just to show you an example. Of course, this middle slide right here is a spur. This picture right here is a combination of both. This is a Haglund's deformity, a large portion of the heel bone. So typically in a person who has just a Haglund's deformity, they have no bone spur. But typically in a Haglund's deformity, we do not need to detach the Achilles tendon. The Achilles tendon is attached down here. So when a person has just a pure Haglund's deformity, we can retract the Achilles tendon, get to the bump and shave it off like we did here. And then there's no need for soft tissue anchors. So a person is typically bearing weight on their foot much quicker and back to activities much quicker than in a person who has the spur that requires detachment from the heel bone. So I threw a lot at you in this period of time. The difference, I guess, is the location of the bone enlargement. I'm getting ahead of myself, I'm sorry. So again, to go back, I guess I already had the pictures here, I apologize. But again, on the left, we have the spur, pure spur. You can see it's normal rounded back of the heel bone, so they don't have a Haglund's deformity here. But on the right side, you can see they don't really have a spur here, but they have this sharp peak of bone on the back of the heel bone. And right here, you can also see how, if you look at the shadow right here, you can see how fat the Achilles tendon is right here. And that's because of this bone constantly irritating the Achilles tendon. So again, that can cause damage to the tendon itself, but by removing this spur, this enlarged portion of bone, it relieves a person's symptoms. This is another example of a person having this. On the left is a calcification within the Achilles tendon, and this over on the right is a combination of the spur, insertional Achilles tendonitis, and Haglund's deformity over here. This is just an MRI showing the inflammation of the Haglund's itself. So we can see not only does the Achilles tendon hurt because of the irritation, but the bone itself, oftentimes a person can say, my heel bone hurts. And this is just an example of showing inflammation within the bone because the bone is being irritated by the Achilles tendon. Same treatments, rest, ice, anti-inflammatories, no steroids. So oftentimes, again, back to Haglund's deformity, it's it oftentimes is a little simpler than the insertional Achilles tendon surgery. Again, very tight calf muscles can be the irritating factor and the cause, and at times a person may require the recession of the gastrocnemius itself. Postoperatively, if the tendon can be retracted and it doesn't have to be detached, and there's no damage to the Achilles, a person can typically bear weight on their foot pretty quickly. But even though a person is bearing weight on their foot pretty quickly following the surgery, they're typically in a walking boot for a good 6 to 8 weeks. This is just another example showing removal of the, on the right, you can see the Haglunds and the spur, and on the left, you can see the removal, and the same with the bottom pictures here. That's it. So I was getting at is I threw a lot at you. So these are 3 other common causes of heel pain. That's it. I hope you enjoyed my talk. So I have some time for some questions. Very good question. So yes, you can be formed. There can be congenital Haglund's deformity. So the answer is both scenarios are possible. Typically, a person is born with a foot structure that leads to Haglund's deformity. You know, well, if I use my hand here, if a person has a higher arch foot, if my hand is the heel bone, and a higher arch foot, the heel bone is tilted upward. So the Achilles tendon is more easily irritated, or there's more friction. Whereas if a person has a flatter foot, the Achilles tendon, I'll use my other hand, I'm sorry. So the Achilles tendon, when a person goes to take a step, the Achilles tendon pulls straight upward. So in a person with a higher arch foot, there is more friction between the two. So it's more of the foot structure. Higher arch foot structure is more common congenital cause of Haglund's deformity, but there can be a pure congenital or born with enlargement of the heel bone at times. So we can see children pretty young with this issue, and it's very common in people who ice skate quite a bit as well. So we'll see it often in young kids who spend a lot of time in skates, because the skates, the back of the skate is very hard and rigid. So it causes a lot of friction on the heel bone. So at a very early age, the friction on the heel bone or the pressure against the heel bone can cause the heel bone to enlarge. You get a Haglund's deformity. What can be very difficult to tell the difference between the two. So sometimes a person can also have a combination of both, believe it or not. So the best way to, typically in general, although it's not 100% of the time, typically a common symptom of plantar fasciitis will be a person has pain with their first few steps following rest. So that means they can sit for a while and they go to get up and the first few steps are extremely painful, or they can get out of bed in the morning and with their first few steps they experience severe pain. So oftentimes that can be a diagnostic symptom for plantar fasciitis, whereas with tarsal tunnel syndrome, the pain tends to increase the longer a person is on their foot, because over a period of a day or a period of time, the pressure is building up in the tarsal tunnel. And also the tarsal tunnel pain oftentimes can have a more nerve-like characteristic, tingling or burning sensation. But the reality of it is that it can be very difficult to tell the difference, and that's why you have to have it examined. So foot and ankle specialist, that's what we do. That's what we can differentiate between the two. all depends on how long you want to deal with the heel pain. So typically, the sooner a person addresses the heel pain formally, the quicker their symptoms will, the better chance they have of getting rid of their symptoms quicker. Heel pain is a very, very common problem. Myself, I've been in practice for several years, but I see myself, I average over 2,000 patient visits a year just for heel pain, just for plantar fasciitis pain, not even the other causes of heel pain. So it's an extremely common problem, and it's a problem that there is an extremely large amount of information on the internet. So, which is a good thing and a bad thing, because it can also lead to a lot of frustration. So it's very important, a person can get rid of plantar fasciitis pain easier if they come see us at 2 to 3 weeks than they can when they come to see us it's been hurting them for 24 months and they want their heel pain better before they go on vacation next week. It's just not going to happen that way. It's not a realistic expectation. So it all depends on how long you want to deal with the pain. As soon as you have pain, it's easy for me to say because I'm the doctor and I realize life gets in the way. But the sooner you have it evaluated, the better. Sure. Massage can be beneficial if there's a tightness. So they're actually different massage techniques that can be very beneficial, and physical therapists often are skilled in those techniques. But also, for instance, plantar fasciitis, if the plantar fascia is inflamed, if we keep pressing on the plantar fascia, it's not necessarily going to make it better. Or if there is inflammation within the tarsal tunnel, so there's already irritation, and we keep pressing on the irritated area, it's not necessarily going to make it better. So it's not, sometimes there's not a lump that needs to be worked out for tarsal tunnel syndrome. So it can be beneficial, but sometimes it can be detrimental. Well, it depends on what type of surgery you have. And every person is different. So it can be stretching exercises to loosen up your calf muscles. It can be strengthening exercises to strengthen the muscles in the front part of your foot and ankle. You could have weaknesses in the hip, in the thigh. You can have weaknesses or tightness in the other limb. So that's a very broad answer, but it's a very broad question as well. So it's a very difficult question to answer. Every patient is different.